Okay, and he'll just do no charting and no texting and no playing with their computers, and just pay attention because it's showtime. Okay, the first thing I want to tell you is I'm a geriatric nurse practitioner. I actually have worked in nursing homes for years, and I know what you do. I've done it with you, okay? I know what the aides do. I know they are the ones that have the almost minute-to-minute contact with the resident. I know the nurses have to oversee that and depend on the aides to get the information that they need in order to deliver the best possible care they can. Okay? And I believe and know that the reason why we're here is because we care about these people. Okay? Like I said, I'm a geri nurse practitioner. I do this. I don't live in some ivory tower and make up rules for you to follow. This is also to show you that my background is that I'm also a wound osteoincontinence nurse. I helped write the guidelines for pressure ulcers that are known nationally, okay? I've published a lot of papers, and so I'm from this part of Texas, but I've been educated here, and I've worked here, and I help take care of residents here. Okay, so we're going to put some pieces together about what you know and what I can help you learn about taking care of people with wounds. Okay, the National Pressure Advisory Committee got together in April of 2017 and made a lot of changes in wording. Okay, we no longer say pressure ulcer, is a pressure injury, okay, which has caused a lot of computer going in and erase this and change that, okay? And the reason was because not all pressure develops in an injury. The other thing is they've used medical devices as a cause for pressure injury, like lying on a Foley catheter. They've removed the word suspected from deep tissue injury. It's either a deep tissue injury, it can be suspected, but it doesn't just stay suspected. And they've changed the staging. We no longer use Roman numerals for stage 1 and 2 and 3. We use numbers, okay? And now there's 6 because they've added to the 4, they've added a deep tissue injury and what we've always known as being unstageable. So what is a pressure ulcer? Well, it's actually localized tissue destruction caused by squeezing tissue between bone and some hard surface, usually a bed surface or a chair surface. The etiology of pressure is this. I want you to look and see that the pressure comes down on the skin, but the damage actually occurs at the bone level. Okay. And any time that the skin slides across the bed, that's friction. Friction injury is not pressure. Okay. So if you have a resident that's scooted up in bed and they slid their skin off, that's not pressure. That's a friction injury. The other thing that you need to know is note the damage is at the bone level, not at the skin. And that's so important because for years, and the way we talk about staging, it sounds like stage 1s go to 2 to 3 to 4s, and that's not the truth. And we'll talk about why. So when do you assess your resident? In long-term care, we all know as soon as they hit that door, we look at the skin, okay? And then they need to be reassessed weekly for about the first 4 weeks, and then it can go to quarterly unless there is a change of condition, which means if you have a resident who hasn't eaten for 3 days, that's a change of condition and it's time to do another skin assessment. Does that make sense to you? Okay, and then long-term care, you may not know this, but patients usually develop pressure injuries within the first 4 weeks of being admitted to the facility. Why do you think that is? Do you not pay any attention to them the first 4 weeks they're here? No, because they're probably sicker when they first come in and you don't have as much information. So what are the risks? Well, the risk is real. We've seen it a gazillion times. You look at your Braden scale, okay? Now, the problem with the Braden scale is when your resident is first admitted and you do a Braden scale, you don't know any of this, much of this stuff. I mean, you ask the family how they're eating and they, oh, he eats 100%. And then you get him in the dining room and he eats like 10% or he just pushes the tray away. Or they say, you know, oh, he hasn't got any problems with his memory. And then you find out, oh, yes, he really does, okay? So you can't really count on your Braden on admission. And if I ruled the world, I'd have to go back and do it again in a week. Okay, so the identification of risk, there's other things besides what's on the Braden scale, and that is they're sicker. I mean, if someone has heart failure, okay, and COPD, they're not getting the oxygen to the tissues that they need to get, okay? If they have on some kind of steroids and they have a wound, steroids keep wounds from healing. If they have any kind of disease where the blood doesn't flow, like arterial disease or heart disease, you can count on them being more at risk. If the resident refuses some of the care, then you're going to have a hard time delivering the best nursing care that you could if they didn't refuse. And that's something I want to point out to you. A lot of times we use the word non-compliance, and that gives a ring that, well, they're non-compliant, but if we just said the right thing or told them how to do something the right way, then they do what we said. So here,
line one.
We live in Texas, and everybody knows everyone has the right to choose. So I want you to stop and redefine when you're talking about a, quote, non-compliant patient, because what they're really doing is choosing to do something different from what you recommended. So in your care plan, instead of saying non-compliant, I'd like for you to say, this has been done, this has been taught, this is how we have prepared the care plan, but the resident chooses to eat candy and drink Cokes despite his diabetes. Patient choice. The other thing is they can be cognitively impaired, exposure to urine and stool, if they're undernourished, if they have if they've had a previous pressure ulcer, okay, they are more at risk to break down in that place than they are if they hadn't had that ulcer. And then the initial stage 3 and 4s are more likely to have recurrent breakdown. Okay, so let's look at the Braden scale, and you think about which of the things that you can actually eliminate on the Braden scale. Can you eliminate, can you change their physical condition? No, not really. Can you change their activity? Yeah, you can do something about that. You can get them up and moving and get PTOT or whatever. Can you do anything about immobility?
Change their mobility status.
Right. And then, can you do anything about their mental condition? Not really. Can you do anything about continence? You can keep them clean and you can try and keep them dry, but you really can't cure their incontinence. And then can you do something about their poor nutrition? Yes, you can find out what their food choices are, and you can get foods from home and do those kind of things. But if they refuse to eat, there's really nothing you can do about that. So what I'm telling you is use your Braden scale as part of your care plan. Okay. You address the things that you can fix, And then in the care plan, you document what you can't fix and why you can't fix it in the care plan. So every day you need to do a daily skin assessment, and then who really is going to look at that skin? The aides, right? Okay, and then you need to do the pressure relief, which is turning, positioning, and providing a support surface. And I want to tell you this, I'll bet you all the studies that have been done about turning someone every 2 hours on a mattress, I'll bet you anything that you do not have a standard hospital mattress in this facility. I bet most of you don't even know what a standard hospital mattress is. The standard hospital mattress was about 6 inches, was covered with a hard plastic, and so what you really need to know is that you already have pressure reduction surfaces in this facility. So when your resident is admitted, you need to know that they have been placed on a pressure reduction surface. Okay, this is what you need. You need a head-to-toe assessment every day, and any skin changes should be documented, including description of the skin changes as well as what you did about it. And then CMS says that these things should be noted every single day by nursing assistants. You need to pay attention to the skin color, the skin temperature, the turgor, and you all know what that is. You pull the skin up and whatever. The integrity, which means are there any breaks in the skin? Are there any splits? Are there any rashes? And then moisture status. Are they dry? Are they diaphoretic? Are they sweaty? Okay. Okay, repositioning. This is really critical for people who can't move by themselves. You need to pay attention to how much they can move. You need to pay attention to their general medical condition. You need the overall treatment objectives. What are we trying to accomplish here? Okay. If you have a hospice patient, your goals will be entirely different from someone that you're intending who's going to go home. Okay? And then the skin condition and then comfort. Okay? One of the reasons why we turn and move people is for comfort, not just to protect their skin. Stop and think about if you had to lay on your side or your back without moving for 6 hours or 4 hours, or sometimes even 2 hours. We are constantly moving and shifting in our sleep. Positioning, there's something called a 30-degree lateral, which this is a picture to show what it is. If they're on the side, they're not lying directly on the bone of their greater trochanter and they're off their sacrum. You have to pay attention to the bones that are touching in between the knees and the ankles. So you put a pillow or something. Okay, and this is 30-degree. I think it looks great on paper. I never could get anybody to stay at it. Okay. Then, so what you really need is small, frequent shifts. When they talk about turning a patient, you don't need to turn them completely from side to side. You just need to change their position. There's a veterans hospital in Breckenridge, which is in Houston. And what they do is every employee, when they walk by a bed, they bounce it. Okay? Because what they're doing is they're relieving and reducing the pressure so the blood can flow through whatever is being compressed. Okay? So pressure reduction, you need to elevate the heels. That's not what I mean. The high heels aren't going to get it done. You need to elevate with the pillow. The thing I want to tell you about the pillow is that when you put a pillow underneath of someone, you need to have the heels suspended from the bed, just enough that you could slide a piece of paper under there. And you need to make sure that you've got support underneath the knees, because if you just have it underneath the calves, then you're putting stress on that joint. Ask your closest PT how to do that. They're good at positioning. You need to move bedpans promptly. This was a patient that I had at the hospital that they kept her on a bedpan all night because she had diarrhea. Okay, that was back in 1983. Okay. We now know that that was a deep tissue, I now know that that was a deep tissue injury. At the time, she was a nursing home patient in her 80s, and we discharged her from the hospital. She went back to the nursing home, and she came back to the hospital in 3 weeks and died from this injury. You need to position any injury exposed to pressure. So if someone has pressure on their greater trochanter or on their sacrum, you need to position them in bed so they're not lying on that ulcer. And then you need to choose an appropriate support surface. Here's what pressure redistribution is. The purpose of pressure reduction is for a patient to float in the mattress. And here's how I can explain that to you. Think about sitting in a bathtub and there's no water in it, and how hard that is on your bottom and your heels and your elbows and everything that you're touching. Now put the plug in the tub and you turn the water on, and as you begin to float in that water, that reduces the pressure on all the places that have been exposed and hard, okay? So what we really do when we put someone on a pressure relief mattress is we are floating them in the mattress. So this is a picture of what happens. On the top picture, that's on a standard mattress, and you can see that there's all kinds of pressure on that coccyx and on the sacrum. But on the pressure reduction mattress, there's floating down in it, and that pressure is being redistributed over the whole sacrum. So therapeutic support surfaces, the effects of you know why they need them. And then the other thing is there's a product, a material called Gore-Tex that cuts down on shear. We'll talk about shear in a minute. And you be sure that the mattress is functioning as prescribed. So you need to know that when someone is on an air mattress that they're actually floating in that air, and you can take your hand and slide it between the mattress and the air mattress, and if you can slide your hand in there. If you can't, then they're actually not floating in the mattress, they're just laying in a puddle of air that's lying on the bed. Seating and repositioning. The time that an individual spends seated in a chair without pressure relief should be limited. Probably someone who's in a wheelchair or on a chair, an hour is probably the most that you should let them sit without repositioning them. You don't have to move them clear out of the chair. Just bend down and lift them up for a second, okay? Or just move them from side to side. Many clinicians recommend offloading for dependent residents. Wheelchairs are meant for transferring, they're really not meant for people to sit around in. The WOCN, the Wound Ostomy Continence Nurse, has a really good algorithm online that's free that will help you choose a support surface appropriate for the patient or the resident that you're looking to help. Okay, we're going to talk about shearing forces. I skipped something. Now, shearing is different than pressure. Shearing is caused when a resident is sliding down in bed. Their skin stays stuck to the bed, but their skeleton is moving down. And so what happens is that happens, it kinks off the vessels. Okay, just like that water hose. Okay, if I had a water hose and I kinked it together, you wouldn't get any water flow. The same thing happens when someone slides down in bed. They kink off those vessels, the ones that go from the bone up to the skin, and kink those off, and there's no blood flow through them. And when there's no blood flow to the tissue, what happens? It dies. So the etiology of shear is someone is sliding, the head of the bed is higher than 30 degrees, and they're usually wheelchair that you've got the bed propped up too much and they're sliding down in the bed, or they're what we call sacral sitters. They're in a wheelchair, and instead of sitting straight up, they're sliding down. Okay, and they're sitting on their sacral, they're sitting on the lower back instead of the bottom. So typically, pressure ulcers occur over bony prominences. They're deep, they're full thickness injuries that begin at the muscle bone. Do you hear me? Pressure ulcers begin at the muscle and bone layer, not at the skin. Okay. And then the reason is because muscle has a higher metabolic rate than skin does. It needs more oxygen than skin does. So when it's not getting enough oxygen, it breaks down more quickly. When shear forces are involved, there's undermining and tunneling are common. And I want you to think about why that may be. If I'm sliding down in bed, I'm kicking off the vessels more at the base here than I am up higher on my back. So at the base, you're going to have more tissue damage than you will at the top. Am I making sense? So the helpful hints are this. If you have a pressure injury, it's generally round, okay? Just like if I put a saran wrap on a bowl or even a square pan, and I push my finger down on that saran wrap, you can almost see those concentric rings of energy, okay? It's generally over bone that's directly in contact with some surface, either the bed, a chair seat, or another bony prominence. Knees, okay, ankles. Now, shear injury are generally triangular. Remember, I said because it kinks off the vessels more at the base than higher up the back. They most always have undermining. So if you see a wound and it's got undermining, it's probably a shear ulcer. Okay. And putting them on a pressure reduction mattress is not going to help that much. What you need to do is make sure that they're positioned and not sliding down in the bed. They're on the wheelchair. And you'll find that paraplegics generally have shear ulcers, not pressure ulcers. Yes?
What is undermining?
I'll show you a picture. But what it is you see your wound edge and the base of the wound, and then you'll notice that sometimes at one, like maybe at 1 or 2 o'clock, but someplace in the wound, it's deeper. Okay, and it'll be deeper, maybe half of the wound is deeper than the rest of that. And the skin's on the surface, but it's wounded underneath of the skin. It's undermined. Okay, that's a good question, thank you. So all wounds are not pressure injury, okay? I lived in a time in the 1980s when I first became a wound nurse that everything was a decubitus. Okay. So the most important thing is, what is the cause of the wound? When you see a wound, the first thing I want you to say is, what is causing this? Because if you don't treat the cause, it's not going to make any difference what else you do. If you have a cough and you go to the doctor, he doesn't find out what's causing the cough, it's not going to make any difference. Maybe he's lucky and it throws cough syrup at it and your cough stops. But it could be something else. Okay? It could be allergies. It could be, heaven forbid, it could be TB. It could be pneumonia. It could be all kinds of things. So you've got to find the cause of what the wound is. You need to know the cause before you can treat it. So we're going to talk about another thing. Pressure injury, Pressure injury. These are pressure ulcers. Okay. They're from pressure causing damage at the bone level. This is incontinence-associated dermatitis, IAD, and it's inflammation of the skin due to skin contact with stool and urine. Okay? They're not pressure injuries. So the implication for you is you need to look at that skin breakdown on the buttocks and decide whether it's pressure or whether it's from incontinence, because of the cause makes a difference. Okay, you've got layers to your skin. You've got the epidermis, which is the top layer, which you can see. The dermis underneath is what you can see when you've got a sunburn and the blister breaks. Next layer is a subcutaneous layer, which is the fat, and then there's muscle in the bone. What you need to know is how deep the wound is depends on how it's going to heal. Top down versus bottom up. Top down are partial thickness wounds. They're broken blisters, they're scrapes from friction, they're incontinence-associated dermatitis. Okay, and they occur in those first two layers. Bottom up are full thickness layers, injuries, and that's what occurs in the subcutaneous tissue and the muscle in the bone. So the way wounds heal, regardless of what the type or how severe the wound is, it's only going to heal in one of two ways. Either regeneration, okay, which occurs in the first two layers, or replacement, which is what has to happen with a full thickness wound. And this is how your skin looks, okay? So in a partial thickness wound, what happens is there's a cut or an injury in the epidermis and the dermis, and then those, my thing didn't work. Anyway, what happens is those skin cells split and make two cells. That's the way they heal. They regenerate. One cell becomes two cells become four cells. So wounds confined to the epidermis and dermis regenerate. Now, partial thickness wounds are top-down injuries, which are incontinence, skin tears, friction, stage 2s. If it looks like a broken blister, it's a partial thickness wound. Okay, like that. Healing by replacement. Wounds extending below the dermis heal by replacement, replacement and scar formation. So that's that, and then this is what happens underneath of that. You need to replace the hypodermis or subcutaneous, muscle, and bone. But you need to know that once subcutaneous tissue is gone, it's gone forever. And once muscle is gone and destroyed, it's gone forever. And once bone is gone, it's usually gone forever. Sometimes it can regenerate. So what I'm telling you is at stage 4, if the muscle is gone, it can never turn into a stage 3 because the muscle is gone forever. Okay. The stage 3 cannot turn into a stage 2 because the subcutaneous tissue's gone, it's gone forever. And I want you to think about a scar that you know has been full thickness. You can tell there's no fat tissue under that, and there's no muscle under that, and you can't move it. It's immobile. You take that scar and you try to move it, and it's stuck where it is. So full thickness healed by replacement. You can see that the granulation tissue fills in from the bottom up, and then the skin grows over top of it. The edges can't be brought together. A layer of granulation tissue gradually fills the wound, and then wound contraction brings the edges together. That it shrinks and pulls, just like any other wound that you have. And then complete closure is a scar. Now you need to know that a healed, closed wound only has 80% of the strength that the skin had before you had a breakdown, which is why it's so likely that someone's going to get, if they're exposed to pressure, they're going to develop another pressure injury in that same place because it's not as strong.
I have a question.
Yes.
I don't know if you know this is not, but if we have a pressure injury that is like stage 4, and it's not gonna get better, right? If they're open and you can see into it and the nurses step in and clean it and we take care of it, it's not gonna heal back. That hole that's on their toxin is not gonna heal.
It all depends on whether your resident has the resources to repair that. They have to have the right nutrition, they have to have the right protein, they have to have the right things. If you have a terminally ill patient, a hospice patient who is dying, skin is not going to get better. Okay. But you can heal the stage 4. Okay. And I've had patients that we did that, but they were generally healthy people to begin with, like maybe a 20-year-old man that was in a car wreck, and they couldn't move him for 2 days because of his spinal injury.
So if you're younger, you have a better chance.
If you're healthier and younger,
Okay.
healthy is the thing here.
And if you're old and healthy, you can heal.
Yes.
Age doesn't necessarily mean it's not going to heal. You have to have all the factors.
So have you ever seen like a stage 4 where it's like you've seen inside and everything that it's actually healed over and
I'll see if I have a picture of that. Yes, I've got several pictures of that. Okay. But I'll tell you this, I have never healed a wound. The resident, the patient healed themselves. All I did was provide the best clinical knowledge that I had to help that patient heal themselves. Okay. Partial thickness wounds, you need to choose dressings that will maintain a moist wound surface to protect it. Okay. A full thickness wound, you need to choose dressings that will help that wound bed matrix regenerate itself. So dressings and treatments, you've got to use clinical judgment and protocols based on professional standards. And there's all kinds of books out there that'll help you. And then choose the dressing based on the wound assessment, what your treatment goals are. Your goals may not be healing. If you've got a hospice patient who's in pain all the time, you are not going to be doing dressing changes every 3 hours. Okay. And then manufacturer's recommendations. 4 Ds for dressings. This is what I live by. If it's dirty, you clean it. If it's got debris in it, you need to debride it. You need to get the dead stuff out of there. If there's drainage, if it's dry, you moisten it, like with gels. If it's moist and not draining, just serous coverage, you just maintain that moisture, okay? Like a foam dressing. And then if it's wet, you absorb it, which would be your calcium alginates. If it's deep, you need to fill it. You have to have dressings down in that hole, okay? That you can't put like a dressing over the top of it, okay? And you need to fill up that cavity, okay? Pressure injury, what are you ignoring? You need to set your wound care goals. What do you want to happen? You need to find out what caused it, okay? Can the resident heal? Can they heal? Are they healthy enough? Do they have enough blood flow? Do they have enough oxygen? Do they have enough nutrition? Okay. Is the patient committed to the plan? Y'all, been there, done that, okay? I told you I'm a real nurse. Okay. If you have a resident patient who doesn't care, you're just beating your head up against the wall, but you document that. They're choosing, okay? They're not non-compliant, they're choosing, okay? And then what is the wound status? And what is their quality of life? Is healing that wound going to add to their quality of life? What will be the response and chance of the patient overcoming the cause? Okay. What caused the wound? If the wound was caused because of uncontrolled diabetes, it's not going to get better unless you control the diabetes. Okay? So now you need to tell the difference. Now I did this on purpose. I took this off the internet from the National Pressure Ulcer Advisory Panel because this is one of the biggest problems that you run into is stage 2s. I promise you in 5 years' time there will be no stage 2s. They won't. They're going to go away. They're not going to call them that. There's infighting right now. Okay? Because stage 2s are top downs. And I've already told you that pressure ulcers are bottom ups. So there's just all this infighting about it's hard to get rid of something. Okay? But at this point in time, you can say a stage 2 is located over bone. The patient is dependent on repositioning and it defined contours over areas exposed to pressure. Now, what you don't stage and what is not a stage 2 is anything that's being caused by trauma. Okay. Friction. Sliding on the floor, sliding up and down in bed. Incontinence-associated dermatitis. Those are not stage 2s. Don't put yourself in a box where it looks like you've developed a pressure injury when it's actually from incontinence. Contrary to previous assumptions, pressure injury occurs from the bottom up, not the top down. And I know this is real hard for us to grasp because we've been told forever in our nursing education that if someone has a red spot, you got to move them because it's going to get worse and turn into a 4. No, if they have a stage 4, it was a 4 to begin with. Okay, and that's what happened. Okay, that's what happened years ago when all these lawsuits went on, and now we bad nurses weren't taking care of the patients. What happens is the injury occurs at the bone muscle layer and takes a few days for it to show on the surface. So the necrosis is at the bone level and then it travels to the top, which is why it looked like there was a stage 2 and then 2 days later it was a 4. No, it was a 4 the whole time. Does that make sense to you? I see you go, yeah. And of course you never massage. Okay, so incontinence associated is a top down. You can see how it ulcerates and the skin gets raw. Assessment parameters, you stage pressure injury only. You don't stage incontinence. You don't stage venous stasis. You don't stage arterial ulcers. You don't stage diabetic ulcers on the feet. I hate staging, you can tell that. They're not the most important parameter. Once you've decided what a stage is, just forget it, okay? And I would suggest that only one person in this facility stage, okay? Just because it doesn't help anything else. Staging doesn't help you choose dressings. Staging doesn't help you decide whether a wound is going to heal or not. It's just something to fill out on a piece of paper and state loves it. Okay. They like that a lot. They love it. So anyway, the point is since it doesn't matter about your patient care, have one person stage. One person, I could have 10 wound ostomy continence nurses in here and show them wounds, and not all 10 of us would agree. Okay. How can you look, other than a quote stage 2 that looks like a broken blister, how can you look down in a wound and tell me what you're seeing? It takes an excellent understanding of anatomy, which I just said, and it's based on the National Pressure Ulcer Advisory Panel. They've now said that mucosal membrane injuries are not pressure injuries. Here, I'm just going to go through these quickly. This is a picture, a graphic of what skin looks like: epidermis, dermis, subcutaneous tissue, muscle, and bone in a white person. This is how it kind of looks in a black person. Okay, the only thing different is the melanin and the epidermis. Okay, heals the same way, looks the same way, does the same thing. Okay, blanchable and non-blanchable, that's supposed to be the difference between a stage 1 and a stage 2. If you take your hand and push here and it turns white, that's blanchable. If you see a red place on someone and you press on it and it stays red, that's non-blanchable. Now that means that you need to be moving them around because there's pressure there. Stage 1 usually has swelling. Stage 2, stage 3 is down into the subcutaneous. This is a pressure injury with pibulate. That's a good word. Okay. Pibulate means that ideally, what you want to happen is the granulation tissue to come up, reach the surface at the same time the skin gets to the edge. Then the skin can just go over the top. Pivotally, what happens is the granulation tissue didn't get there in time. The skin's there and it doesn't have any place to go. So what it does is it curls under itself and causes a roof. Now the problem with that is, once you've got that roof, that epidermis can seal together. It's just like if you taped my 2 fingers together and forever and untaped them, I'm still going to have 2 fingers because I've got epidermis on both fingers. You can scrape the skin off of one of them and tape them together, and all that's going to happen is the skin's going to grow back on the second finger. However, if you were to scrape the skin off this finger and this finger and put them together, then I'd end up with 1 finger. Okay. So what I'm telling you is, in order for a wound to heal, that skin has to get there at the same time that the granulation does. Well, what happens is it forms a roof. Can you see that? Can you see how it's grown under? Now that wound isn't going to heal until you get rid of that roof. Now the ideal thing would be to get the doctor to cut that off. It's hard to get him to do it. But sometimes you can get some silver nitrate and get someone to do that for you. I always used a curette and just cut it, just stripped it off. But if you're working on a wound and your granulation's slow coming up, take a piece of gauze and just kind of rub that epidermis to keep the edge raw. Deep tissue injury. This is a new stage. What happens is there's necrosis at the bone level and you're not able to see it on the surface. And then this is an unstageable that's filled with black eschar, and there's an unstageable that's filled with slough and eschar. All eschar is, it's dry slough, and all slough is dried out. Slough is dried out stuff that turns into dry stuff. Wet stuff turned to dry stuff. And stage 4s. Okay, stage 1s. This is a resident that I had. She had a barrette in the back of her hair and leaned back against her wheelchair and got the red stage 1. Okay. What I'm pointing out to you, was somebody mean to this lady and made her get a stage 1? No, they were making her pretty when accidents happen. Staging deep tissue injury. Please be careful with this. If it's purple or maroon or looks bruised in any way, please chart that it looks, when someone comes in from the hospital, if it looks bruised, if it looks purple, if it looks maroon, please write down purple or maroon. Okay. Without doubt, without a doubt, do it. Okay. Because it could be a deep tissue injury, and in 2 days you're going to have a stage 4. Okay, because it's there. Okay. It's discoloration in intact skin. A blood-filled blister is a deep tissue injury. We used to call those stage 2s or anything we thought, on heels. It was a blister. They're difficult to see in dark skin, and they can involve, sometimes they get better, and sometimes they get worse. That's a deep tissue injury. See that? That's a deep tissue injury. Okay. These are stage 2s or partial thickness. Okay. They present as a shallow open injury with a red-pink base or open ruptured serum-filled blister. If you see a serum-filled blister, it could be a 2. If it's blood-filled, then it's a deep tissue injury. Okay, do not classify incontinence-associated dermatitis as a stage 2. Look at these pictures. Those are not pressure ulcers. Okay? Those are all incontinence-associated dermatitis. Every one of them. You cannot get pressure in the gluteal fold. Okay? There's no bone in there. Okay? None of those places have bone underneath. This is a stage 2 with the loss of epidermis. This bottom picture, you can see that it has the little capillary bumps. I cheated on that. That is not a pressure ulcer. That was a burn. But it was the best I could show you about what dermis looks like. Okay. There's stage 3s. Okay, they're full thickness loss. Subtissue may be visible, exposure of bone. You won't see muscle, you won't see bone, you won't see tendon. Now the problem with stage 3s is this. I've been doing this for almost 35 years, and I do not think I have seen 10 stage 3s I bet my paycheck on. Okay. That bottom picture is my picture, and it's been nationally published. And the reason is because it's the only picture anybody can come up with that the fat shows. Because fat has no blood supply of its own. If it has no blood supply, what's going to happen? It's going to die. If you have dead tissue in a wound, can you stage it? No. So that's why I'm telling you I'm having a hard time with stage 3s. Stage 3s you cannot tell by depth alone. I can have a stage 3 on my cheek, okay, that would be, what, 2 centimeter deep. A stage 3 on my bottom could be down in the fat tissue. It could be 4 or 5 inches. So you can't tell me what a stage 3 is by how deep it is. You have to tell me what tissue you're looking at. Okay, stage 4s are easy. Okay, because you see muscle, you see bone, you see tendon. Okay, slough and eschar are common. Okay, see that, well, I don't know. That's a pretty good picture of undermining, but not real good. That's actually a tunnel. Maybe I've got another one. Okay, these are unstageable. You can't see the base of that wound. You cannot tell me how deep it is. You cannot tell me whether that is down into muscle, which would be a 4. You cannot tell me whether it's a 3 because you can't see any fat tissue. It's unstageable, the depth is unknown, it's full thickness, we know that, okay? But the wound is obscured. Okay, if the wound is only partially covered with necrosis and you can see tendon or you can see bone, go ahead and stage it as a full. Okay. You can't stage it if there's only subcutaneous tissue. Okay. Assessment parameters. Let's talk about pain. Pain's really important, okay? When I first learned how to do this, I was told that stage 4s weren't painful because there weren't any nerves down in there. Okay. Where does that roll? Okay. Where does that roll? So you need to find out a way to establish whether your resident's in pain or not. I've actually had someone from housekeeping stand in a resident's head and tell me whether or not they grimaced when I moved them or turned them or was doing a dressing change. Okay? You need to relieve whatever causes the pain. You need to know what your wound care does on the severity. You may have a resident who's already in pain, and then you do wound care and it hurts worse. You need to tell the doctor that. You need to get a PRN or something to do, give that resident before you do the wound care. Here's how you determine whether your wound's getting better or not. You need to do serial assessments. You need to look at this wound next week, look at it again, and compare it. Okay? Compare it. And you don't write down what somebody else wrote the last time you assessed it. You look at it with your nurse eyes and you assess it. You need to see the signs of progress, and what signs of progress are is there's less dead stuff, there's less swelling, and there's less redness. Signs of progress be more granulation tissue, less necrosis, more granulation tissue, more skin, more epithelialization. If there's no progress in 2 weeks, that's all I'm giving you, 2 weeks. If there's no change in size, if there's not less necrosis, if there's not less drainage, then it's time to change the dressing procedure. It's time to get hold of the doctor and say, this isn't working. Definition of insanity is doing the same thing over and over again and expecting different results. The drainage should decrease and there should be less pain. If you think about it, and that's how I could always tell one of my resident patients was getting a wound infection. As things the reason we have drainage is because your body's trying to wash out the necrosis, the dead stuff, or whatever. So the more dead stuff you've got in the wound, the more drainage you're going to have because your body's trying to wash it out. As the wound improves, you should have less and less drainage. You all know that if you have a pain, if something's going on, as you get better, the pain decreases. So if you have a resident who's suddenly getting more drainage, or they start complaining about pain, you've got something going on. It's not progressive. Healing, 2 weeks. Partial thickness wounds, stage 1, stage 2, should show signs of healing or be totally healed in 1 week to 2 weeks. Stage 2 should be all gone 2 weeks' time. Okay. Full thickness wounds, stage 3s or 4s, should show a decrease in size, less drainage, less pain, less necrosis. And if there's no signs of healing in 2 weeks, you notify the doctor, you request a change of treatment. Your documentation should be, you do a complete assessment and documentation on a weekly basis. And then when you're doing dressing changes, if you documentation at each dressing change about any status in the wound bed, if there's a change, if it's got yellow in it now, if it's developing necrosis, if it looks pinker, if it looks redder, you talk about the volume of the drainage, each dressing change, okay? Any change in the surrounding skin or tissue. Is the skin more red? Documentation should include the type of injury. We should say whether it's pressure, whether it's a surgical wound, okay, whether it's a venous wound, it depends on a specific type. You stage your pressure ulcer and get it over with. The progress toward healing, identification, and potential complications. Resident has a stage 4 and has developed a urinary tract infection, running fever. The wound may slow down in its healing. Okay. If infection is present, the presence of pain, what was done to address it, and the effectiveness of the intervention. If they're in pain, what did you do about it, and did it work? And then a description of the dressing and the treatments. Notify the doctor if the resident has a change in condition that could increase risk. Increase in wound size, that's not good. An increase in drainage, an increase in odor, which let's talk about odor just 1 second. Okay. Any wound is going to have an odor if you're doing once-a-day dressing changes. The way you check to see if the wound actually has an odor, change the dressing, take the dressing off, clean the wound, get the dead bacteria out of there, and then see if the wound has an odor. You cannot tell by the dressing itself. If you have redness around the wound greater than 3 centimeters and no signs of healing in 2 weeks. Okay, thank you for your time. Do you have any questions?